Thank you for joining this informational video by the North Carolina Department of Health and Human Services Communicable Disease Branch. Today we will be discussing acute flaccid myelitis, also known as AFM, and how to appropriately investigate suspect AFM cases. As a reportable condition in North Carolina, there are many moving parts when there is a suspect case. Let's dive into steps and best practices for investigating AFM cases. In this video, we will cover 4 main topics. We will begin by discussing AFM background, review the reporting process for AFM and the basis of specimen collection, go over a few technical details, and finally, we will do a quick summary. Let's start by discussing the background of AFM in North Carolina. AFM is a rare but serious neurologic condition that affects the gray matter of the spinal cord and the areas where motor neurons are found. Cases are usually young children, less than 7 years of age, and they often present with acute flaccid limb weakness, and reflex and cranial nerve weakness may also be present. Weakness generally starts in the proximal muscles before moving to the extremities. North Carolina sees an average of 2 cases a year, but historically there have been higher annual incidences associated with even years. During these higher incidence years, cases most commonly occur during the fall months as respiratory season starts to pick up. However, during odd years, cases tend to be spread evenly throughout the year. AFM has multiple potential viral etiologies, although our understanding continues to evolve. Enterovirus D68 has been commonly detected among cases, especially during high incidence years, appearing to drive those outbreaks. AFM patients have been found to have antibodies to enteroviruses in cerebrospinal fluid more often than non-AFM patients. However, viruses such as West Nile virus can also cause AFM, as can other enteroviruses besides enterovirus D68. The Centers for Disease Control and Prevention, or CDC, first started surveillance of AFM in August of 2014 after a group of children were noted to have developed acute limb weakness following a respiratory-like illness. Since this time, there have been 760 confirmed AFM cases throughout the United States, with cases reported from 49 states and DC, excluding Delaware. As previously mentioned, and as seen in this graph, AFM seems to have a biannual increase in incidence pattern. North Carolina added AFM to the reportable condition list in 2020. There is rapid decline of strength in patients once neurologic symptoms develop. This rapid progression is the reason we underscore the importance of having a high index of suspicion to quickly get patients to institutions with pediatric ICU capabilities. Headache and neck and back pain are common neurologic symptoms, as many of these patients have concurrent meningitis. So these are the classic meningismus symptoms that they can have. Patients will need access to all diagnostic modalities, subspecialty services, and a pediatric ICU. So if your facility does not have these resources, arranging for transfer to a referral center is urgent. AFM treatment may include IVIG, steroids, and/or plasmapheresis. Given the rarity of the disease, however, there are still no targeted antiviral therapeutic treatments available. Physicians may recommend physical or occupational therapy to help with limb weakness. Due to the incomplete understanding of which small subset of infected patients develop AFM, standard precautions to reduce the likelihood of contracting a viral disease is the best preventive measure at this time. Next, we will review the process of reporting a suspect AFM case. AFM is a reportable condition. For all suspected cases or people under investigation, AFM diagnoses must be reported to the North Carolina State Communicable Disease Branch within 7 days. This can be done 2 different ways. For the first, you may call the 24/7 epidemiologist on-call line to report a suspected case. Or, if you are in a hospital network that has public health epidemiologists, also known as PHEs, they can contact the Communicable Disease Branch on your behalf. The North Carolina Communicable Disease Branch will facilitate submission of materials to CDC, as case review and classification are done at CDC. Laboratory testing is also done at CDC to classify enteroviruses, as well as to rule out polio. Testing protocols are still being developed as CDC conducts research on the condition. Even though the CDC will test and evaluate cases, this takes weeks and is not meant to replace testing in the acute illness workup. We expect that providers will ensure cases are admitted to an appropriate hospital with access to diagnostic equipment and a pediatric ICU. It will also be helpful to have pediatric neurologists, pediatric infectious disease physicians, and pediatric ICU providers available for consultation. There are also many state and national resources available. It is recommended that providers perform a full neurologic exam and order diagnostic tests, including specimen collection and imaging, especially MRI of the spine, as well as ensure suspected cases receive appropriate supportive care. North Carolina State Communicable Disease Branch facilitates specimen submission and shipment to the CDC laboratory. The state is also required to complete a patient summary form that they will work with hospital staff to complete and submit to CDC. This form includes patient history, physical exam findings, neurologic exam, and infectious disease consult notes, as well as MRI images and the discharge summary if available. The state will also notify the provider of the CDC final case classification after their review. This is likely to be weeks later and should in no way impact the treatment plan or any course of clinical care for the individual. CDC's case classification uses the AFM epidemiologic case definition and is not a clinical diagnosis. This is a resource from the CDC that gives more detailed explanation on the background of suspect cases as well as when and how to report them. The link is available in the video's description and can easily be printed and displayed in a clinical workspace. Additional CDC resources are also listed within this PDF. As mentioned previously, CDC conducts its own investigation with a panel of AFM experts to try and learn more about AFM etiology and epidemiology. We will now talk about the specimens needed for CDC's investigation. To give a scenario, once a patient presents with limb weakness, it is expected that the State Communicable Disease Branch will be alerted of a potential case. All appropriate specimens should be collected, and an MRI and lumbar puncture should be performed. Then the State Communicable Disease Branch will coordinate with CDC to transport specimens to their lab. At the same time, the physician should proceed with making an independent diagnosis and executing their treatment plan. Separately, CDC will reach a case classification for the individual, which, as a reminder, will take weeks to complete. CDC requires multiple specimens for their investigation. These include stool, CSF, respiratory swabs, and serum. Specimens should be immediately frozen, and the State Communicable Disease Branch will obtain approval for submission to CDC and ensure specimens are shipped correctly. Physicians will want to collect enough sample to perform 2 sets of testing, one for their local testing and one to be sent to CDC. It may help to speak directly with your laboratory to be sure they know not to discard leftover specimen as soon as they set up their local tests. Serum should also be checked for anti-MOG and anti-AQP4 or aquaporin-4 antibodies in-house, as there is overlap with how these autoimmune conditions and AFM present. Pathogen-specific testing results from CDC are also unlikely to be timely. This graphic is a resource for specimen collection. If possible, please collect both a nasopharyngeal or NP and an oropharyngeal, or OP, swab. Remember that the state communicable disease branch will ensure submission to CDC. To ensure transparency, we will review a few technical details of working through AFM as a diagnosis. In the initial investigation, the first crucial step is to consider poliomyelitis. Since detection in New York in 2023, polio as a diagnosis is not impossible. Be sure to ask about immunization status as well as travel history. Other countries still see polio outbreaks and continued spread. Travel history is also an important piece when assessing settings for enterovirus transmission. AFM cases often report having respiratory or gastrointestinal illness in the days to weeks before limb weakness. Remember to loop in the state communicable disease branch. Even if you decide not to pursue an AFM workup, the communicable disease branch will be able to help guide the process. As AFM is a rare condition, we wanted to point out some other differential diagnoses that may be considered. Viral myositis and musculoskeletal infections in children can present with refusal to use a limb rather than inability to use the limb, and the limb in these cases will also be very warm and tender, which is not like AFM. Guillain-Barré syndrome, or GBS, is an ascending paralysis, whereas AFM typically starts in the proximal limbs, spreading distally, and is usually asymmetric, infecting one side of the body more than the other to start. Tick paralysis should improve upon removal of a visible tick. Toxins such as botulism can also cause muscle weakness. Also to note, acute flaccid paralysis is an umbrella term under which both infectious etiologies of AFM would fall, as would non-infectious syndromes like Guillain-Barré syndrome and botulism that may lead to limb weakness. Although an apparent concept, we want to underscore the importance of distinguishing the inability to use a limb and the refusal to use a limb. Keep this in mind when assessing young and possibly nonverbal children. Most pediatricians will be familiar with bone and joint infection, and AFM presents differently from those. As a session recap, there are still many unknowns concerning the AFM condition, but the CDC is actively researching using data collected from suspect cases. Where appropriate, it is important to consider AFM when developing differential diagnoses. If you have a suspect AFM case, or you have questions regarding AFM or any of the topics mentioned in this video, the North Carolina Epidemiologist on Call is available 24/7 at 919-733-3419. Remember, the sooner cases are admitted to the hospital, the better their clinical outcome will be, and always consult with neurologists, infectious disease specialists, and pediatricians at your facility or a referral facility with pediatric specialists. Finally, CDC case classification should not be a factor in case workup, diagnosis, or treatment of suspect AFM cases. Listed here are some references that may be useful. These are also linked in the video description. Additionally, I would like to note that the AAP website has links to more extensive versions of what was discussed in this video. This is through a free online course through AAP PediaLink that you may register for. There is also a great article that includes a consensus set of AFM guidelines, which is the one listed at the bottom of this screen. Thank you for listening to the presentation, and reminder, you may contact the epidemiologist on call with any question 24/7, 365 at 919-733-3419.